to summarize on pelvic injury questions, earlier there were questions posted on how long should the pelvic wrap be applied, and should external fixator be applied immediately. So just to give you a short summary, on our lecture, it was said that at least within 24 hours, based on the experience of our speaker, more than that, the control of the bleeding is already possible. So there was also a question regarding the arterial control of the pelvic bleeding, which was also addressed. Only the arterial bleeding in cases of endovascular control.
Yes, so I would also like Dr. Balogh to respond to my observation, especially in those cases, in those centers which are not that much resource fulfilled, like your center or the centers where ready angiography is available, and therefore my interest would be to ask you that if you suspect an arterial bleeding, or if you have a case in which you cannot perform a CT scan because the patient is dying of exsanguinating hemorrhage, and you find that there is an offending pelvic fracture also on exploration of the abdomen, what is the role of bilateral internal artery ligation? That was also one question, especially in those situations. Either way, you cannot get a prior CT scan and angioembolization, or you do not have facilities for angioembolization. So we, in India, many of the trauma surgeons would resort to bilateral internal artery ligations with good results in terms of hemorrhage control. What are your views, Dr. Balogh, on that?
Thank you very much for bringing this topic up. I think you need to be a very experienced and fast surgeon to do that efficiently. And I agree with you, that's a last resource. And it's in selected cases where are already in the abdomen, the pelvic retroperitoneum is open, and you see arterial bleeding hosing from everywhere. I think it's a good choice. There are other options as well, which people are practicing, not much published, that you tie off the proximal end of the internal iliac and mix up some gel foam and blood clot and inject into the distal part of the internal iliac to make sure it clots off. It's quite a full-on thing. I haven't done it, but it's been described, and I heard some surgeons in the United States of America practicing that. The internal iliac, bilateral internal iliac ligation obviously have complications, such as sloughing of the pelvic floor, the gluteal musculature, and the pelvic organ ischemia. But as you described, this is in terminal exsanguination cases, so anything is better than obvious death.
Thank you, Dr. Balogh. We recently published the bilateral internal iliac ligation in our setup, more than 150 cases. But the normal mentioned complications which you just now mentioned, we've hardly seen that. Dr. Raj, any experience with the bilateral internal iliac ligations open, or if you've seen any complications after bilateral angioembolization?
So the role where the usual situation where we're doing internal iliac ligation directly is usually when we're already in the abdomen, and we then notice large pelvic hematoma, and we're trying to address that on top of whatever we're already addressing in the abdominal cavity. And that's when I have ligated internal iliacs as a faster way of getting there rather than putting in a sheath and embolizing. And these are usually in patients who are really quite unwell, and you're trying to get some kind of emergency control. Because of the good collateralization, I've never really had a problem with ligation of the internal iliacs before. And even if I extrapolate to the fact that sometimes we do prophylactic embolization of the internal iliacs in pelvic trauma in patients who are shocked and we are concerned whether there's a spasm, or if you have a CT which shows a blush, but your angiogram doesn't show it, and we are prophylactically embolize your internal iliacs, I've never really encountered pelvic ischemia in these patients. Now, again, this is again in the context of a young patient age group, young patients, good collaterals, no significant vascular disease. So that may be playing a part as well. In an elderly patient with very poor vasculature, calcified vessels, you may have a slightly different outcome by knocking off both the internal iliacs. I think in that group, we may have to be a little bit more concerned. But again, I think as all the speakers have talked about today, at the end of the day, it's all going to be about stopping the bleed. And if that is what is required to stop the bleed, then you will have to undertake it and deal with the consequences thereafter.
Thank you, Raj, for that reaction. I would like to go ahead with Dr. Ken Mark. Dr. Kenneth, I just wanted to ask you, since you are also a hepatobiliary surgeon, and we just now had a talk on hollow viscous injury also, I would like to have your views on, if not a proper laparoscopic surgery, what is the role of diagnostic laparoscopy? Because we've been doing a lot of diagnostic laparoscopy, especially in equivocal, sort of physical findings or equivocal CT findings in stable patients, obviously. So what's your opinion regarding the role of laparoscopy in trauma?
Thanks very much for the question. I think there is a limited role for laparoscopy in abdominal trauma. But it's important that if you are carrying a laparoscopy, you understand what it can do and what it can't do. I have carried out laparoscopy interrogating what is penetrating injuries, if only to assess whether it's fascial breach, and then making a decision from then on whether or not to progress to a formal laparotomy. And I think the use of laparoscopy in that sort of setting is in fact very nice. And it saves sometimes a big incision being made for a patient, especially if I'm convinced there's no fascial breach present in a penetrating stab wound. But I found that laparoscopy has limitations, particularly when I'm walking the bowel, looking for hollow viscous injuries, particularly when I'm getting to the duodenum and the DJ flexure. I found it a little bit more challenging in my hands trying to assess in that particular area, and therefore where I'm particularly concerned about injuries around the pancreato-duodenal head, I've not resorted to laparoscopy, and I've still continued with open surgery. So I have a more limited experience with laparoscopy. Raj may have a little bit more experience in that, and I'll be keen to hear whether there are alternative views by the other surgeons.
Professor Razman, any experience with the diagnostic laparoscopy, whether after that you converted to an open one, or especially in low velocity penetrating trauma? That's where most of the indications would be.
I think with regard to the role of laparoscopic surgery or for diagnostic laparoscopy for trauma, I think even for penetrating injuries, there are quite clear guidelines on how to approach. I think in regards to that roles, in normal practice, I still perform diagnostic laparoscopy, but with limited kind of experience, in the sense that I think the threshold for conversion is always high, especially in a situation where the patient is not stable. I do have evidence of hemodynamic instability, but otherwise, most of the time, I think the patient that turn up to our centers are basically those with a quite definitive emergence or immediate laparotomy rather than the usage. However, having said that, I think there may be a role in certain cases where you do have already a certain kind of, these are the cases where I tend to have some kind of I would say, equivocal findings, whether to go in or to explore, definitely, or there is a role of conservative. These are the cases probably I think I may embark on that kind of situation, especially if it's related with a non-solid organ injuries, like a possibility of perforations or those kind of things, because sometimes the clinical presentations are not quite very obvious. There may be a role of a diagnostic laparoscopy in that kind of situation. That's my opinion about that.
Thank you, Professor Razman. I would like to ask Dr. Zol Balogh, how early is, would be possible? Is it 24, 48, 72? Obviously not beyond that, probably.
Yeah. Thank you very much. I think the right balance is find a balance between systemic inflammatory response and coagulation. So the short answer is that if you take the patient too early back, obviously you risk bleeding. if you keep the patient longer with PECs in the abdomen, that is severely pro-inflammatory, and the inflammatory response is going to get worse. So my answer is this: as soon as the patient's coagulation parameters are settled and you're sure that they're not going to be further bleeding, then you go back and preferably remove the PECs and aim for reconstruction. Now, earlier there was a problem with lots of edema with crystalloid resuscitation, so that took days to settle. Today, with hemostatic resuscitation, we see these patients taking back in 24 hours, and the gut is not edematous because we haven't blown them up with positive fluid balance. So as soon as the hemorrhage under control and the patient general condition allowed, there is no reason to wait for a magic number of 24 or 48 hours or whatever.
Thank you, Dr. Balogh, for that clarification. Dr. Wee-Beng, any other pressing questions in the list of questions you would like to ask our panelists?
I think perhaps just one more question, and it's been asked a few times as well. Is there consideration nowadays for the use of a diagnostic peritoneal lavage or aspiration to diagnose injury in both small bowel as well as other traumatic solid organ injuries? Perhaps I can direct this question to Professor Yasumitsu.
Thank you for your question. Your question is the role of the diagnostic peritoneal lavage in the blunt injury. Is that? I think in Japan, the diagnostic DPL is not yet used in the most institutions. Its sensitivity and specificity is not so high, and we can. I think the CT is much preferable to repeat diagnosis for the injury, which needs the operation. And if the patient is not with the head trauma or comatose patient, we can have signs of the peritonitis. So it is important to check the peritoneal sign to decide if we need the operation or not. And when the patient have a head injury, we do a temperature control. We use some the peritoneal signs. So we have to be cautious about missing the abdominal injury. But the DPL not so used even in such a comatose or head injury patient. I think the CT is much more used in the Japanese institute. Thank you.
Professor Kenneth Mak.
Thank you very much. The answer is yes. I have had to bring patients into theater more than twice because you have to count the first damage control surgery as the first time. And often that's because when I went in the second time, the injuries I found were a little bit more complex. I had concerns that I was taking too long, and I chose then to phase my repair and bring a patient in a third time. The situation that is fresh in my mind was when I had a patient with a grade 5 injury to the pancreas, and I chose at the second operation to carry out what was effectively a trauma Whipple's operation, but I didn't reconstruct the bowel. I in fact brought him in a third time and did reconstruction in a delayed fashion as well. Whenever we operate on a patient, I think it's important for us to assess what the physiologic status of your patient is, what injuries you find, and what needs to be done. And we have to be mindful that it's a very tenuous balance. Even though you made every attempt working with your intensivist to resuscitate your patient, ensure your patient is physiologically optimized as much as possible by the second operation, but he still sometimes remains in a very precarious state, and you still have to make a decision about what you want to do at that second operation, whether or not you think your patient would be able to tolerate completing a definitive repair, or whether or not that definitive repair also has to be staged. And if need be, we should not be worried about bringing a patient a third time or fourth time. Another setting where I could easily imagine this occurring is where there were degloving injuries actually present. And then a patient might have to come back into for surgery repeatedly for wound debridement and cleaning of that wound, even if it's in the abdominal wall or elsewhere. So there are many instances where we might not be able to complete all repairs of organs, injured organs, just at a second operation. And if that were the case, then we may have to carry on with repeated surgery.
Sure, please go ahead.
Okay, I mean, this is from Professor Kim to Professor Kenneth Mark regarding the repair of a liver parenchyma injury. He's asking what type of coagulation products you would use. Do you think is best for the liver parenchyma?
Thanks a lot. Actually, I've used a variety of different products, and to some extent, it would depend on what I have available to me. What I have a particular fondness of is actually using TCL or equivalent. That's just what I have available in my operating theater. But I use them to supplement the repair. I don't use them often in replacement of repair. So looking at the advertisements of how people use flow seal, I mean, I've seen people do it. I've used it in a pig, but I still have a preference of making sure that I put a stitch in and control bleed, and then only after that then consider augmenting with hemostatic agents. I think whatever is available to you, wherever you are, there are many different agents that can be used to supplement, but I don't rely on it exclusively. It's a facilitator that helps me to augment my repair, but I still trust my hands, I still trust a suture, and I still trust my needle holder.
Thank you, Professor. Back to you,
Dr. Wee Meng, and thank you, Dr. Kenneth, for your responses, and thank you all the faculty on behalf of the Asian Collaboration for Trauma for joining us, and all the reactors also for joining us.